Oh, we're live.
It looks like we're now live.
We are now live, yes. I think all the sound quality is good. Um, I'll be tweaking the quality from behind the scenes, behind the curtain. So um, no worries there. Just
Okay.
please, you know.
And I believe at some point you're also going to feed me questions from the site because I can't see the site and the screen at the same time.
You can or cannot.
Cannot. The
Okay.
live part doesn't allow me to, I don't believe, see the questions.
Ah, okay. Then in that case, yes, I'll feed the questions to you, yes.
Okay, great.
Uh,
So should we begin?
Yeah, well, so along those lines, everyone is welcome to send in questions through the Q&A or the comment section of the Google Plus Hangout event. We also are taking questions via Twitter and our blog. So with that, please, yes, please begin.
Okay, great. Welcome to everybody who's been waiting out there. I can't tell if you can see us because I can only see the big American Anthropology Association symbol on the screen. But my name is Julie Livingston. This is the web roundtable on the Ebola epidemic in West Africa. Oh, hi. There we are. Our presenters today are Adia Benton. She's an assistant professor of anthropology at Brown. She holds a PhD in social anthropology from Harvard and her MPH in international health and infectious disease from the Emory University School of Public Health. She also has her bachelor's in human biology from Brown. Her work focuses primarily on the politics and cultures of health institutions, the issues they prioritize, and the communities in which they work. Among the topics that she studies are HIV/AIDS, infectious disease, epidemiology, gender violence, and access to surgical care. She is the author of HIV Exceptionalism, Development Through Disease in Sierra Leone, which we're all looking forward to. It's coming soon from University of Minnesota Press. We have with us Jackie Lacey. She's Curatorial Associate of African and Pacific Ethnology at the American Museum of Natural History. The two major themes in her work currently are the intersections of infectious disease epidemiology, medical anthropology, sociology, and Anthropocene studies, as well as analyzing museum discourses on African culture and technologies. She's done some collaborative work, including a conference she convened at the museum, Collecting the Future, Climate Change, Museums and Communities, and she's working with colleagues in New York and Samoa on another project on climate change in New York and Samoa. She has a background in virology and medical anthropology. And has worked in public health education in Tanzania, HIV/AIDS testing and research, an African Services Committee in Harlem, and in an immunology lab at Sarah Lawrence College. Hoping that he will be able to miraculously join us through this crazy technology is Robert Hahn. He served as epidemiologist at the CDC since 1986, and he's a member of the Senior Biomedical Research Service. He received his doctorate in anthropology from Harvard and his master's of public health and epidemiology from the University of Washington. He's the author of Sickness and Healing, An Anthropological Perspective, and co-editor of Anthropology and Public Health, Bridging Differences in Culture and Society. And last, but certainly not least, we have with us Mike McGovern. He's a professor at University of Michigan, a political anthropologist who's worked in West Africa for a long time. He uses a variety of sources, from kinship idioms to the aesthetics of state-sponsored folklore, to try to understand post-colonial states within the longer arc of historical trajectories. He's taught anthropology at Yale, and he was also the West Africa program and project director for International Crisis Group, the Brussels-based think tank that analyzes causes of armed conflict. So without further ado, let's get to the topic at hand. So maybe we'll begin by asking how we as anthropologists might best collaborate with public health policymakers during such periods of emergency. What advice or insight would anyone on the panel like to offer to those who are now setting up Ebola containment measures in Guinea, Sierra Leone, and Liberia? Who'd like to field that question?
I can jump in a little bit and say that I think that one of the most important things to keep in mind is to take something that Ann Kelly said to NPR recently and look at cultures not as stumbling blocks but as collaborators in terms of making this a more robust public health response and looking at the partnerships and linkages that can be made with people locally, and doing that in a more meaningful way and in a sort of more deeper, more thoughtful way can help to eliminate some of the frictions and the tensions and the fear and conflict that's happening between people who are responders on the ground coming from abroad and people who are living locally with the epidemic.
So I'm wondering if it might also help to back up on what, because I think one of the things that a lot of people don't know is that there are certain ways that the outbreak is supposed to be managed, or at least protocols. And so, as Jackie pointed out, there's the containment piece, but the question that was raised didn't necessarily address that there are multiple kinds of responses happening on the ground. And the first one is trying to isolate people who have been exposed, which is one piece of the puzzle that's caused a lot of trouble. There's making sure that the people who are being treated and are isolated are actually being cared for with the supportive care that's provided for Ebola, and food and shelter and all of that other stuff. And then there's another dimension, which is the continued tracing and tracking of people who might have been exposed during all of these different points in the incubation period. So the time from the person begins to, well, not really the full incubation period, but from the time that a person starts to experience symptoms and the time that they become, and all of that other stuff needs to be taken into account. So this is all the epidemiological and public health response that has to happen and has to take place. And so there are multiple points at which, as Jackie pointed out, that collaboration is key.
And are there particular nodes along that trajectory or in that kind of three-legged system that you just described that you can think of where an anthropological insight or knowledge might be of particular utility?
So I've been talking to anthropologists on the ground, and the ones who are in Liberia and Sierra Leone have been primarily, or not primarily, but have had a really interesting contribution when it comes to funerary practices, when it comes to hunting and the hunting and how meat is being butchered and things like that. So they're looking at human-animal interactions, human environmental interactions, funerary practices, other kinds of ceremonies that may attract a large number of people. So so that's the first piece that I actually forgot in that other part. But there's also trying to make the isolation and quarantine and all of those other things much more humane. So how is it that you can convince someone to send a family member into the hospital at the right time? Of course, we're still facing a shortage of beds. So even if you are able to convince people that they should be treated or that they should be looked after, there's still that limited capacity to do so.
I think it's a really challenging thing to ask of ourselves and to try to answer. How do we put together humanistic, culturally competent, culturally plugged in responses in an acute medical crisis? I think this is something that the timescale of the public health infrastructure, the medical infrastructure, the virological infrastructure, and the sort of standard pace that people are used to with anthropological response, there's a bit of confusion on timescale in terms of at what point in time does the anthropological intervention become relevant. A lot of that has to do with trying to create pre-existing networks prior to outbreak events that put medical anthropologists at the ready to deploy in both on the ground in affected areas, but also in other places as well. And I know that this is something that's been definitely discussed elsewhere in terms of how do we create that network in advance. Of course, we can't do that in this epidemic, and so I think the question becomes now, how do we create those partnerships quickly to help create sort of translations in the different languages and the different epistemologies that all of the different stakeholders are using, and being reflective about institutional cultures. This is something that some of us were talking about this morning, the institutional cultures of foreign aid organizations that are coming in and perhaps not, aren't afforded the opportunity to see the different networks of knowledge that already exist, the different conceptions of disease that already exist in the ground in the places that are being affected.
Maybe related to that or following from these comments, of course, on the one hand, we have the public health infrastructure, both at the national, the regional, and in terms of the foreign and NGO players who've been involved in this. And then we have rural communities and urban neighborhoods that, as we understand from some of anthropologists who have been commenting on this, have begun to organize their own responses around protection, caregiving, burial measures, maybe monitoring who comes in and out of a village, etc. And I'm wondering what, if anything, you can tell us about ongoing local responses and what kinds of resources, knowledge, forms of social organization there might be in these communities to draw upon, given the infrastructural limitations that we see around containment right now.
I can actually, I can start because I've been talking to some folks and so Twitter and Facebook are fabulous things, and to do something like a remote anthropology, which it feels like what I'm doing right now, is definitely a tool. And so I've been following some citizens groups. And I've even talked to a woman who is the head of a women's organization that's doing a lot of mobilization. So for weeks, groups in the U.S. and that I know of here, and even in Rhode Island, and groups in Liberia and Sierra Leone are taking, all kinds of supplies like chlorine and gloves and all of this into the communities as part of these hygiene kits. But they're also going out and doing like house-to-house, door-to-door education, lots of outreach and dancing and singing and that kind of stuff that you come to expect from sensitization activities. So to some extent, I think people are, and I've also heard of people who are barricading their own villages and saying, we aren't letting people in and out without making sure that they're okay, and so there are these kinds of small-scale initiatives that are taking place.
This is a region that we know is still recovering from a period of war, and I'm wondering what impact you think that's having on how the epidemic is playing itself out, and also on popular responses to government, NGO, and international efforts. Maybe that's different in each of these three countries, or maybe there are resonances that some of you can talk to across the region.
Well, sorry.
You want to go, Jackie?
Oh, no, by me
follow
too.
you.
Yeah.
Go ahead.
Oh, okay. What Adi was just talking about with the villages that are self-quarantining, I think that it's important to recognize the autonomy of local places, see how this plugs into pre-existing conceptions of public health containment. Barry Hewlett did fantastic work during the Ugandan outbreak, taking a look at indigenous conceptions of quarantine, and wrote about how we can partner these pre-existing knowledge networks with public health interventions. So maybe taking a look at how we can address indigenous or local responses, and phrasing those and framing those not as resistance, but as a natural extension of how people are reacting to their political history, to the history of the Civil War, and realizing why the inclination might be to pull away from the larger international infrastructure and to deal with this on a local level. That's maybe not something that needs to be surmounted, but something that needs to be part of what is respected in the response, and sort of a natural extension of the history of conflict in the region.
Mike, did you? Oh, your sound went on.
I
Okay.
think we lost the last sentence there from Jackie. Yeah, when I was in Guinea when the war came over from Liberia in 2000, people cordoned off their villages and they patrolled the borders and the bush paths coming in. And they're doing exactly the same thing in a lot of villages in Guinea now in the same context. And so the ways of managing flows of people and things in times of insecurity have a lot of similarities between wartime and time of epidemic. And, you know, it hasn't figured a lot in the journalistic accounts that I've seen, but we shouldn't forget that smallpox was only eradicated in West and Central Africa in 1970. So there are people alive who remember how they managed smallpox. And certainly within living memory, the whole series of techniques that people used of variolation to inoculate people, using the pus from the smallpox from the people who had it to inoculate people who hadn't gotten it, the ways that people were put into houses that were built in order to quarantine those who had smallpox. That kind of knowledge exists in villages in this region. And it's not that different from the techniques and the knowledge that gets deployed to manage times of violent insecurity. So just as war is important in this story because of the fact that it's part of what caused the health infrastructure to be so degraded, which is part of the cause of why the epidemic has taken off the way it has, it's also a big part of people's conceptions of how they ought to manage insecurity.
Maybe continuing somewhat along these lines, can you give us a sense of how porous the borders are around the Ebola-affected zone, both the borders in between these three countries, but also so that we can better understand what this might mean for Ivory Coast and Mali?
Mm-hmm.
I mean, I say that with, you know, the need that we recognize that Senegal has done an excellent job of containing cases that arrived there. Right now, it would seem to be a better job than Texas, but maybe you know,
I like that. I like
right.
that.
The jury is still out. I don't mean to call Ivory Coast or Mali necessarily into question, but to just say this is where the borders lie. And if we can talk about why so far we've seen it contained in the way that it is within the region.
Like I was mentioning before we went live, it's something that I'm very hesitant to speak to too much because of the implications of critiquing public health responses that we don't necessarily know how they're being organized. I think it's going to be important to see the differences in porousness in air borders versus land borders versus water borders where they're appropriate. I think it's something that remains to be seen, but that certainly where there is porousness, it's probably along the more informal borders than the formal borders, and seeing how people are moving through less trafficked areas. I think it's something that we have to be really, really cautious about the implications of how this might spread further regionally.
Yeah, I think it's a hard prediction in general.
Yeah.
Because so when I was a few weeks, it must have been a month ago now, or even more than that, I was talking to a man who lives in Monrovia, and he actually traced the map of how everything happened. He went from Guinea to Sierra Leone to Liberia, and he actually showed me along the roads how the disease moved, and it made me. What was really fascinating about that map and that movement was that it showed circular and kind of radial movement out of that region that was the first affected. And so the way that I don't want to predict anything because I don't work in predictive science anymore, though I study it, is that there is this potential, and I think what happened with Senegal was, you know, we had somebody who had a connection and a tie there, but also a person who knew that the healthcare system was probably better in that sense. And so the things that drive people to other places may not be the ones that drive them, that drove them to different places during that earlier part of the epidemic may be shifting too, right? So I think that's one of the things is keeping in mind the dynamic risk and the dynamic movements of people that had largely been moving in the Mono River region and started to move out as care became scarce, right? So there's this huge, before I finish, there's, I'm also talking in conversation with a mapper, and he was trying to figure out why there were so many cases in Moyamba Junction, Sierra Leone, and I said, oh, that's where you stop if you want to go to Bo or Kenema. That's like, and so it's all of those things that kind of, that seem to be shaping how the epidemic moves, is understanding those patterns and movements. And I'm not sure about those ones with Ivory Coast and Mali right now.
Excellent, thank you. We know that the effects of this epidemic are already far exceeding the significant loss of life that's directly attributable to Ebola. So we know, for example, that malaria deaths, maternal mortality, et cetera, are all rising and may well continue to. Can you give us a sense of what the basic epidemiological picture of the region is, what the expected burden of disease in this area is, and what the Public Health Service was like before it had to contend with this epidemic? I know that many of us use the film Donka about the hospital in Conakry when we're teaching about structural adjustment, but of course that's an old film. So I think many people who are don't work in the region and don't have experience with health services in the region, we have a particular image of what that might look like, and maybe you can help flesh that out for us or correct it in whatever way.
Those are two different. I mean, I think those are they're two related but different questions, right?
Yep.
Because the first. Well, I'm saying it because I've been talking. So I've been in dialogue and conversation with a social demographer who works in the region, and political scientists and epidemiologists who work in the region, who are actually talking precisely about this question about collateral damage, right? So what other kinds of conditions emerge or are being neglected because of the large focus on Ebola, and the data are not clear, right? Because what happens is the surveillance for other diseases and the records for other diseases are also not being kept, and there are also being people who are turned away, and there are facilities that have closed as a result of the outbreak. And so one of the things that's not clear is how many people might be dying of other things. But in places like Liberia, we've seen that the deaths that would have been attributed to malaria or other things are actually being outrun or overrun by Ebola. So Ebola deaths are now the leading cause of death in Liberia right now, if you're using all of the kind of old data from demographic and health surveys and clinic data. This is not true for Guinea or Sierra Leone. But what we can understand is that because of the way that Ebola has kind of tipped the scales, it may be that these cases are being missing, and it may be that other kinds of epidemics could come forward. So, there was a cholera epidemic in Ghana, and other kinds of, there was an epidemiologist, doctor and epidemiologist talking last night about how she thinks one often gives way to the other, and that it's a really difficult balance to try to understand what's happening as a result, what's happening to these other diseases as a result of Ebola. But the second part of your question, I think, was about...
Well, what before the epidemic came, I guess it's related to this question of why specifically these treatment centers are so totally failing to meet demand. A piece of that clearly has to do with the exponential growth of the epidemic itself, but also what was the extant public health capacity on the ground that then had to, to what extent was it dealing with the endemic burden of disease and health problem that this epidemic has now layered onto or broken apart or created new demand in the face of? So I'm just trying to get a sense of why so many people are being turned away from these centers. We saw reports in the New York Times yesterday about the Central Hospital in Sierra Leone, where it's basically become a kind of holding pen. And we know that part of that has to do with the loss of human resources. I mean, I'm calling them, these are human beings. It's terrible, medical workers who have succumbed to the epidemic. But if you could give those of us who don't work in the region a sense of what the system looked like before the epidemic and why the scaling up can't seem to keep pace with the epidemic as it's unfolding, or whether you think it will.
I think particularly we can take a look at Sierra Leone and the pre-existing hospitals that were focusing in Lassa fever, another viral hemorrhagic fever. It's where a lot of the early cases were brought to the Lassa fever wards, and it's also where there's been an acute loss of healthcare workers. The recent article that came out in PLOS ONE, where 6 of the co-authors, several of whom were nurses in a Lassa fever ward in Sierra Leone, had already died of Ebola by the time the article came out. And so when we're looking, Julie, I think you're completely right that we have to take a look at the structures that are in place, the physical resources that are in place, the people that were trained to deal with similar illnesses. Lassa fever, I think, being the closest in terms of a viral hemorrhagic fever, albeit one with a much lower case fatality rate, when all of a sudden the people who were on the treatment, were the caregivers, are all of a sudden filling the existing hospital wards because the spread has jumped up, has accelerated so much. It, I think, creates a little bit of a perfect storm in terms of how you can have an acute swamping of a particular medical facility at a point in time and have the impact of one medical facility closing due to the loss of their healthcare personnel radiates outwards in terms of its broader impact on the local community. The existing healthcare centers that exist when one shuts down, that you have a greater burden that's going to the next, and then they get swamped, and it's a network that is slowly and quickly collapsing under the strain of having to take on more and more cases. I can't speak to Guinea and Liberia quite as well in that regard in terms of their pre-existing conditions that were being focused on in medical facilities, but I know Lassa fever, certainly for Sierra Leone, was one of the disease centers that took a lot of the burden on.
And I should also add that in terms of sheer numbers, we were talking about, so most of these medical schools shut down during the war, and so training of medical professionals, clinicians, was also a problem. And so I think by the last count before the epidemic, there were only maybe 100 doctors in Sierra Leone, 150 in Liberia. So we're talking about really, the WHO cutoff is something like 1 doctor per 10,000 people. These are places that have 4, 5, 6, 20 million people, and so if you have just a few doctors, what's essentially a few doctors, it causes, it's a bit of a strain on the system when people are dying.
Yeah, I think the pre-existing figure for Liberia was 1 for 250,000.
Yeah, and Guinea, the ratio I think was a bit higher,
right?
And yet still, most Guineans I know consider going to the hospital pre-Ebola as being that you go to the hospital to die, right? I mean, it's the last resort, and it's assumed that if you go, you're gonna pass away, and that's before any epidemic hits, and not talking about Lassa or any other sort of extreme cases. This is difficult childbirths and cerebral malaria and all the stuff that most people die from.
I think that's getting a little bit at what my poorly worded question is trying to elicit. There's one way to look at this that says, oh, there's this epidemic, and look at these hospitals can't handle this sudden increase in the volume of patients. But in the aftermath of structural adjustment and then war, yes, there's been rebuilding, but how strong, how much capacity was there in any of these 3 national health systems before we wound up with these very devastating epidemics to contend with? Because I think it relates back to the question of epidemiological surveillance and why it's difficult to track people, why people might be resistant to go to the hospital because of what they expect they might find there and what their association of that hospital is, et cetera, et cetera.
And it's worth saying that one of the reasons that Guinea was a little bit better off is because in the context of sort of socialist to socialist solidarity, Cuba trained a lot of Guinean doctors, and in fact, Cuban doctors worked at the University of Conakry in the medical school training Guineans. So this new influx of Cuban doctors to the region now is actually part of a much longer 50-year trajectory. Meanwhile, when we talk about rebuilding Liberia, for instance, after the war, the U.S. government invested the better part of $1 billion in reforming the Liberian army, and a tiny fraction of that for health. And so, you know, just as the priorities of our government in this country may shortchange education and health, so in our foreign policy and aid policies, donor countries have been shortchanging health for a long, long time. And, you know, at the very moment in Sierra Leone and Liberia, when there was the possibility to actually build stuff up again to some extent fresh, not that it was a tabula rasa completely, but a chance to start over, health was simply not high on the priority list.
It's also a matter of the types of health that get invested in when we're talking about the history of structural adjustment. Resources that go towards health, it always leans heavily towards global epidemiological surveillance, the idea of what is dangerous in a place that might spread outward and create outward-radiating political and economic impact as perceived by the rest of the world. When health is invested in, it's very infrequently the non-infectious disease related. It's very infrequently taking a look at sort of a holistic package of health and quality of life. It seems to be focused very much on keeping threats from a biological scale from emanating outward, which is sort of inherent problematic construct.
There's another side too. Oops.
Oh, good.
There's another side, which
good,
is
good.
This is the other thing that I study, which is there are specific groups for which public health is tailored. These are the things that are measured globally, which is maternal mortality, infant mortality, under 5 vaccination, and that and child and birth spacing, right? So and fertility. So these are the things that actually occupy quite a lot of and infectious and specific infectious diseases, the ones that have the highest burden. So we're talking about malaria, tuberculosis, HIV, though the region is not heavily HIV epidemic. So the fact that there's a small group of people for whom public health is concerned, from under five children and women only if you're reproducing, it kind of changes. It skews what health should look like, but it definitely is supposed to be the biggest bang for the buck. Mm-hmm. It's the low cost, low tech, whatever that is supposed to be the crux and the part of the primary healthcare system. And I think the ironic part is that comes from a leftist. It's like it's a leftist ideology in one sense, because it was always about sort of grassroots, low tech, appropriate technology stuff. But in some ways, it also plays into the sort of neoliberal cost effectiveness model.
Absolutely.
And so this is the push and pull and the strain that people deal with when they're dealing with primary health care and public health systems more generally.
Moving maybe outward a little bit from the specific questions around health and broadening the lens, we can already see that travel is being restricted, quarantine and cordon sanitaire have interrupted the flow of goods and markets, but that the response is also pouring tons of capital and resources into the area. We're wondering, what do you envision as both the short and long-term economic effects of the epidemic? and whether I'm going to piggyback onto it, a question that I've just gotten, this little sidebar that I've noticed exists. Sorry, I'm learning the technology, which says, if the failure to implement stronger systems immediately is likely to lead to the progressive worsening of food security and overall security, they're asking the panelists if you could please draw on anthropological research on the state from areas other than West Africa to suggest short-term solutions. So those are two different aspects of the question around food and economy, and how they relate to acute moments where political stability is in question.
I think it's a very good, very important, and very difficult question to address, particularly when we're talking about viral hemorrhagic fever on this scale, because it's still something that I think everybody is still struggling to get a sense of what particularly the epidemiological and the cultural impact is going to be. And it's very hard from the anthropological perspective, I think, to forecast a worst case scenario, because we're very acutely aware of what the human impact on that is. And so I think that we seem to make a series of short-term projections, thinking that the gap will be met somehow with the different types of responses on the ground, trying to bring it under control. I don't think I'm the only one that sort of expects day by day to start to hear the first headlines about various aspects slowing in their worsening. So I think it's very difficult to think, but very important to think about the bolstering the infrastructural capacity when it's difficult to see the way people are mobilizing on the ground. It's difficult to have eyes on that in terms of how people outside of the epidemiological context in particular are able to mobilize and reach communities. I think that the mobility issue is a big and persistent question here.
Am I right in understanding that question was kind of what are the risks of social breakdown and massive?
Yeah, in a way.
Yeah. So
yeah.
So that's kind of a different thing. Yeah. The risks are there. I mean, you know, I was talking to somebody earlier today and I said, there's a chance that Ebola in Liberia is going to be for Ellen Johnson Sirleaf what Hurricane Katrina was for George W. Bush. Right? There's a way in which, you know, mounting disaffection, dissatisfaction can be catalyzed by an act of God or whatever you want to call it, right? This extraordinary event, which of course has nothing to do per se with the government, but everybody starts kind of affixing different kinds of blame for the different parts of the mishandling, and even things that weren't necessarily mishandled. And so the sort of politics of blame then really has much more to do with a cumulative dissatisfaction with the situation. And I would say the political opposition in Guinea, from the beginning of the real blow-up of Ebola in July, has been trying night and day to do this, and it hasn't been very effective. In Liberia, I don't really see anybody, you know, a political party or a group in particular trying to drive this, but it seems to be absolutely everywhere, right? It's in the air. It's what people are talking about, and even government ministers in Liberia are talking about the risk that the whole country could implode. Well, this may be hyperbole, but it's worth remembering that there are a lot of unemployed ex-combatants still roaming around, and that the perception of Ellen Johnson Sirleaf outside of Liberia, which is overwhelmingly positive, is pretty much the mirror image of the way that she's perceived in the country, which for some time has been overwhelmingly negative. And so I think it's Adia can really talk about Sierra Leone, but the place that I worry about the most is Liberia.
I agree in that regard. We're talking about a country that had a 15% formal employment rate prior to the outbreak. And so how are we going to balance discussions about acute humanitarian intervention with using this moment in sort of global visibility to talk about what is needed in terms of infrastructural investment that privileges the needs and perspectives of people living in these areas, and balancing out the short-term and the long-term deployment of what Paul Farmer keeps calling stuff, supplies, and staff.
People and stuff. People and stuff. I don't even remember what it is. I just know that there's stuff.
Stuff, yeah.
Because stuff is really important to him.
Yeah.
No, that's super. Well, I'd say yes. Sierra Leone's probably in a much better position than Liberia. There isn't that same kind of talk, and I don't want to put too much on this, but even the way people perceived that 3-day lockdown, and the fact that he sacked the MOH, and all of those things are kind of part of the kind of political theater of mounting the right kind of response that also is responsive to the needs of people and to the grumbling, right? People grumbled about the Minister of Health for months, but she still got sacked. And everyone knows that, well, I shouldn't say everyone knows, but lots of people talk about the fact that she's related to him in some way.
Yeah.
And so there's a whole bunch of that stuff. But certainly the stuff that I was hearing from my, Liberian interlocutors is very different from what I'm hearing from people in Sierra Leone, which is that although people are dissatisfied about some aspects of the response, the fact that Koroma is not a vilified figure doesn't it helps what is going on right now. So and of course people are talking about with the Liberia thing, they see the military as somehow supporting coming in and supporting Ellen Johnson Sirleaf, right? They see that as part of a response to legitimize her and continue to legitimize her rule.
And do any of you see or have heard of plans in place to secure short-term food security, given the way that this is disrupting local economies and the movement of goods, particularly food supply through the region?
Yes. WFP is on the case. They were announcing food insecurity projections weeks ago, and so they've actually been they've been tweeting frequently. I don't know what that means, but they've been saying, "Oh, look, we're getting the supplies ready," and so that they've actually been on security alert for quite some time. I mean, relatively. And that alarm was raised when the quarantine was set up around Kinema and Kailaun, right? Mm-hmm. Because those are places where people, are often have experienced food insecurity at certain times of the year, but it's also because nothing's moving in, nothing's moving out, or very little is moving in and out. Not to mention the fact that prices went up on food, most foodstuffs, right? So the price of rice doubled, I think, in kind of in that time, around the time that the quarantine came up.
Oh, it surged pricing, absolutely.
Right. So it's, I mean, also the price of chlorine, right? So all of these, the price of everything.
Bleach.
Bleach, yes.
Yeah. And
buckets.
Yeah, gloves. I mean, I'm glad that you're mentioning WFP because I think we also need to mention the fact that they have also said there's something like $75 million short of feeding the 1.3 million people that they're projecting are going to need food assistance in order to make it through this crisis, well as they're being cut off from food supplies, or they're unable to afford to procure the amount of food that they need due to the surge pricing that has happened in the area. The cutoff of supplies being delivered to the area is a huge aspect of what's been going on and definitely being under discussed in the media.
Moving to a different topic or slightly related. The most recent CDC projections include a possible, this is the sort of worst case scenario, in which the virus becomes endemic, at least in Liberia. If this happens, Liberia may well also become a living laboratory for Ebola research. As the historian Greg Mittman at the University of Wisconsin has been writing, this would echo early 20th century period when Liberia was the site of extensive medical research in a program that was run by Harvard, which included the extraction of biological material, so blood, tumors, etc., the use of experimental drugs. And it was a program that many Liberians resisted because it was very heavy-handed in its extractive and exploitative practices. Well, it's been a long time since then, and there are different ethical norms and regimes in place than we would have seen then. But how can we as anthropologists help to ensure that whatever biological research takes place in the name of Ebola, that its ethics are not compromised and that exploitation is not given cover by a politics of emergency?
That's a heavy question.
It is.
It's meant
because
there are only heavy questions here, though.
Yes.
That's a really heavy question. Well, because this is a problem now, like even without the expexperimentation, right?
Right,
Even
precisely.
Before we get to
right,
yeah.
Right, before we even get to the research part, the ZMAP stuff, like who
Yep.
gets that drug and when and under what conditions and who can formally consent.
And evacuation.
Evacuations, right? I mean, there's so many dimensions to this that predate or precede even the research question, which is how far can people trust Western or whatever kinds of researchers to be ethical and just when it seems that the value of their lives is already called into question, right? In terms of response, in terms of how people are differentially valued, and so. I mean, even that notion of the endemic, like an endemic disease, like from the mid 70s, there supposedly were people who actually did have Ebola in Liberia, which means that somebody was collecting their blood samples, which means there's a whole lot of stuff going on.
Right.
So it may very well be endemic already. I think there will be challenges because of this history. There are people who are still alive who remember many of these experiments, right?
Right.
Yep.
He was going to Firestone Plantation to videotape make a film about this. And, that's how people talk about the plantation, right? It's Firestone's plantation for a reason. It continues to operate in that logic as part of the colonial project. That is Liberia. And so, I mean, I hate to be the big cynic here, but I do think that there's always that legacy of experimentation, of the diminished value of life. All of those things play into how people interpret whatever kind of interventions, whether they're research or medical in nature.
And can I just jump on the sort of on that to take it in a slightly different direction, because I did want to address this number of instances where people have even violently rejected teams of people, and this is not necessarily just an outsider-insider thing. In Guinea, a couple of weeks ago, 8 Guinean doctors and political representatives came into a village to educate people about Ebola and were killed. So there have been a lot of media reports about this, and the prevailing narrative has been that people are acting out of fear, they're panicked, it's kind of a Salem witch hunt kind of mentality that's taking hold of them. And in fact, I don't think that's what's going on, at least in the places that I know well. Some of the most violent and sort of aggressive rejections of these teams have been in the forest region of Guinea. And I think actually it has everything to do with that long history that Adio is pointing to, where people have been on the short end of the stick in all kinds of ways, and the state has really been more a predator than a protector. And so then why are you coming in now? We have no Ebola in the village now. Why are you coming to us now? What is it that you want from us? What is it you want to extract from us? And so even, aside from biological material, there's all kinds of other things that states in the region have extracted and that international corporations have extracted and that colonial governments have extracted from the same villages that are now rejecting the good biomedical sense that's being preferred to them. And so I think rather than treating people as sort of simpletons who are overcome with fear and then suddenly start telling people to get out of their village or else they will get violent, there's a completely different frame one could put around these reactions.
Yeah, I think that maybe one of the strongest roles that social science can play in this effort, in this dialogue, is helping to explain to people in the medical sciences, in the biological sciences, explaining the internal logic of what is described as resistance, but actually is a very sensible, very understandable response coming from the perspective of people who have lived with these histories, and working to explain how this resistance is formed, and again, framing it as something other than resistance. I think we need better terminology for that. We need to be able to partner with people who are working on the ground and helping them to understand the semiotic markers that they bear of something that can feel like an extermination rather than an effort to help because of these histories. And I don't think that tapping into sort of that deep historical context, I don't think that's necessarily being tapped into as deeply as it could be in order to reduce the hostilities that are emerging, the flashpoints that are erupting.
We have a question that has come in that I think is related to this from somebody who was talking to a Sierra Leonean friend last week who was complaining that when health educators first arrived on the scene, they used scare tactics to quote-unquote educate people about the dangers of Ebola, and that in turn has led to a severe underreporting of cases. And this person says that it strikes them as similar to the fear campaigns used in the U.S. and AIDS prevention in the 80s and early 90s, which were also remarkably counterproductive in that way. So this person says, my question is, what critical things do you think have been learned or not learned from experiences with previous epidemics in the region?
I think the lessons to be learned are very different because we're dealing with a magnitude that is very different. We're also dealing with a very different cultural context than previous outbreaks, and I think that that's one of the things that gets confused in the media sometimes. I think that there is a tendency to take a look at what has been known with the outbreaks in the Congo in particular and to try to apply some of the same cultural logics. But in general, when we're talking about fear being used as an educational package, an educational response, that pushes people into a space of denialism. It pushes people into a space where they have to distance themselves from a reality that's being presented to them because it is understandably terrifying. That doesn't promote collaboration, that doesn't promote dialogue, it promotes fear and distancing and perpetuating the problem of the shadow zones of underreporting that we're seeing in all three countries.
There's, it's interesting that question came up too, because what I've been hearing from people who've been working in these two epidemics, the Liberian and Sierra Leonean ones, particularly the Liberian one, and so I'm assuming I'm assuming a little bit about both, given I think that was Doug Henry's question. And so what I'd been hearing was that the message was never clear from the beginning, right? Because at first no one really had experience developing the messages for this earlier on. And so what I heard was they started out with the scary stuff, and then they were like, why isn't anyone coming? And then they reshaped the message as they started working with different kinds of communication specialists. But the damage was done for some people, right? So they were like, well, weren't you just telling us that there's no cure last week? And now you're telling us come into the hospital? Like, why would we do that? And so this idea, we're talking about people, I would say people who are actually quite keen to take medicines for things when there's an option to do so or an opportunity to do so. And it's true, there's no medicine, but there's all this supportive treatment, you know, IVs,
Absolutely.
fluid balancing, all that stuff, which is very intensive, low cost and all of that stuff, and basic, but very intensive and requires a lot of work. And people weren't being presented with that option. They were basically being told, don't touch anyone, you'll die, which I think is just like a really hard message to do. And so I think to some extent this is about mixed messages, inappropriate messaging, and something that probably could have been helped if the powers that be had worked together to develop those kinds of communications for this.
Mm. We have one more question, which is reading through many of the reports of the situation, it's clear that health systems in Liberia and Sierra Leone are overwhelmed, and that people are often contracting the disease because they're caring for their loved ones at home. It seems that if families are their primary caregivers, then there should be a focus on providing them with protection equipment. What on-the-ground approaches have been tried or should be to provide resources such as gloves, masks, and education so that caregivers can avoid catching the illness while still performing their familial obligations?
There's a couple things on that one. That's a hard balance. So what the U.S. government is doing through various auspices is they're providing several 100,000 home care kits, which actually do have the chlorine in the gloves. And I can't even remember what else is in it, but there's an NPR article that actually describes what's in it. I had a lot of people asking me because they were putting together home care kits for Liberians and stuff. And so I looked it up. But basically these are there. But the problem, so yes, there are people who are caring in their communities, but one of the problems that we're facing is how far anyone at home can treat people who need to have constant balance, there has to be constant vigilance around electrolyte balances and things like that. That's in blood, you know, the possibility of blood transfusions. So yes, there are efforts mediated by the governments, but there are also people, for example, in diasporas in the US and the UK who are actually going out into communities with these things. And in fact, when I was talking to Paul Richards about his work in the field a few weeks ago, he said one of the things that he had been advocating for because of the difficulty of getting people to health facilities was better education about what women and men can do in the villages, in the community, when they're faced with a possible Ebola case. So that was one of the recommendations that he had made weeks ago based upon his own knowledge of how people were coping, right? There's no way that some people, especially during the rainy season in Kailoun and Kinema, can necessarily on the road and get someone to a hospital or a health facility immediately. And so that was one of the earlier recommendations, and one of the things that, you know, an anthropologist can do just by virtue of being there and by virtue of acknowledging the realities on the ground.
There's been research done with other disease outbreaks as well. I apologize, I don't remember if it was Ann Kelly or Hannah Brown that did the work in Kenya, taking a look at rates at which personal protective equipment are being used by people caring for ill family members in the home, and also by healthcare workers treating other healthcare workers. We know that these are two of the ways in which there's been a particularly high amount of transmission, and it's also, I think, very easy to understand in the context of care and of family why people are less likely to use personal protective equipment when they're treating their family members in their home or when they're treating their colleagues in the healthcare field. But I think it's definitely one of the ways, or one of the places where the messaging can be intensified a little bit, and perhaps destigmatizing the use of personal protective equipment, that it's not necessarily a form of social distancing, but it can be part of the practice of care in the home or care with co-workers.
We've run to the end of unless I've missed some, which is certainly possible, questions that have been sent in, and I believe we've been going for an hour. Do any of you have thoughts, ideas, themes that we haven't covered that you would like to share with us before we end?
Just that I hope that for people who might be watching, might be tuning in more because of the recent diagnosis in Texas, that we make sure that we're keeping attention on what's happening in West Africa, that we're not letting it slip from the headlines and from awareness, and that we're sort of consistently spreading the message of helping people to understand the historical context and the contemporary context of what is happening and why, and that we sort of let this be the time period where the sensationalization of Ebola is sort of allowed to rest a little bit, and that we focus on the very important, very critical structural long-term issues that have been happening for decades and will continue to happen. That we this is not an acute crisis that ends and then slips from our attention, from our awareness. That we persistently keep attention on the issues.
Thank you. Anyone else, or should we leave it with that excellent concluding statement?
That sounds great.
Yeah, that sounds fine.
Yeah, thank you. Well, thank you all. It's been great. Uplifting.
Thank you, AAA, for putting this together.
Yes. Thank you, AAA.
Okay.
Thank you.
Thanks. Bye.
Thank you all for joining us. Just as a note to all our listeners, we will actually be doing another webinar on Africa, although this time on mobile economies on October 15th. We'll be switching back over to the WebEx format, so it'll probably be a little more technologically smooth. But thank you all for attending, and please feel free to continue commenting. I'll be sure to pass along, and we'll be hopefully developing more material on this in the future. Have a good day.
Great, thanks.